Hello, hello. Welcome you to this X-ray test quiz. I will be showing you the X-rays one by one. I like you to describe the X-ray and then give the diagnosis. So let's go on. Please describe the findings and then give the diagnosis. The answer should be coming here, isn't it? There are no answers coming up. Am I audible or not, Mr. Robin? कैसे बात करूं उससे सर लगा के पूछूं then no answers coming up. मेरी बात करेंगे और बंदा ना तो नहीं. हेलो गोविंद का नंबर है क्या कुछ आवाज का तो उसका लगा दो क्या नाम है मैडम का हमारे मैडम okay there's only one answer. Okay, I'll go ahead then. Waiting for more answers. Nobody answering. Oh, this is a very, very simple X-ray. See, the first is the PHS. This is the PHS showing you the calcium. This is the calcium shown calcification all around the heart like this. So this is encasing the heart, the calcium. Then the second picture is a barium swallow, the left anterior oblique view, which also shows the calcium. This is the calcification in the pericardium here, and this is the barium swallow showing the indentation on the esophagus, and that is characteristic of the left atrial enlargement. This picture is classical for constrictive pericarditis, and if you do a barium swallow in these patients, 30% of them have a left atrial enlargement. So go ahead for another X-ray, okay? Oh, I am getting only one answer, that is from Dr. Pankaj. There are no more answers coming. Why? This is an interactive session. There's supposed to be a quiz which is interactive, not a didactic lecture. So I'd like more people to answer it. Well, there is no answer, so I go on and I show what it does show. Actually, somebody has said juxtapose right atrial appendage. The juxtaposition actually causes a bulge in this area, not this. So this is a typical left ventricular configuration of the heart, And then this is the shadow of ascending aorta. Because if it was the right atrium, as we see, it should go straight away. It is just a bulge here at the right heart border, in the uppermost part of the right heart border. This is classical for the ascending aorta dilatation. And this, when you see, it is very characteristic of valvular aortic stenosis. I hope it is clear. Go to the next one. Again, please try to describe why you are saying a particular diagnosis, then give the diagnosis. And these two things, when you are getting in the examination also, the description also carries the marks, not only the diagnosis. So I think get into a habit that if you are shown an X-ray, you give the positive findings and then give the diagnosis or the differential diagnosis if you have any. Again, only one, but this is at least a different person who has tried to answer. But I think we have not tried to analyze it very nicely. This is a very, very typical X-ray. You see it today and try to remember it to all your life. Because such cases are referred to cardiologists as dextrocardia. This child came to us as echo is needed for dextrocardia. And surprisingly, he was carrying an X-ray and nobody had tried to see the X-ray. The X-ray gives a correct diagnosis. This is the abdominal viscera into the thoracic cavity, mostly on the right side. So it is shifting the cardiac shadow, mostly on the left side, so shifting the cardiac shadow to the right. And this is the dextroposition of the heart caused by the viscera which are occupying the most of the left side of the chest. So they're pushing the heart to the other side. As it is a classical example of a diaphragmatic hernia in a child and which was mistaken for a dextrocardia because the heart is felt on the right side. So this is a dextroposition as we call it, and because of the shift of the heart due to the viscera projecting into the uh, left side of the thorax. I hope this is clear. And I think for the students, please keep this in your mind. This is a very typical X-ray, and you will be able to diagnose this condition only on the X-ray easily. Go to the next. I'd like more people to attempt X-rays so that what Sunita wants that it becomes the interactive section, as interactive session, and but only one or two people are answering. Okay, at least two people are there. Okay, you have not got the main thing. This is all right if the heart is on the right side, but a very important feature which I wanted to highlight was that this is the liver shadow which is in the midline, and then the heart is on the right side. The spotty vasculature. Whenever this liver is seen like this in the midline, you are sure that you are dealing with a complicated congenital heart, either right or left isomeric heart, which is called either asthenia or polysthenia. So there are multiple defects, and this is a complex, always a congenital heart. So this gives you a clue. They centrally placed midline liver. And this is a very simple day-to-day X-ray. I think most of you should be able to diagnose it, but I like you to give the findings and then the diagnosis. Good. There are two attempts. One is half correct, one is full correct. But they both are actually half correct because the other one who has given the diagnosis has not described it. You should say it's a normal heart size, RV configuration, typical RV configuration, decreased pulmonary blood flow, and this I may pardon you, this is not very clear in the X-ray, but there was also a right aortic arch. So this is classical finding of tetralogy of cellular, and you are right in saying top physiology, but these all corrected features for tetralogy, and there is no pulmonary bay. So this is a fullness here, which is sometimes there in tetralogy because of a tight impendibular stenosis, and then the upper part may be prominent. So this is features of tetralogy physiology, and the first diagnosis will be tetralogy because there is no other unusual features. And showing you how you recognize a right aortic arch. This is a penetrated view. Many people have a lot of confusion how to diagnose the right aortic arch. You should follow the shadow of the trachea, and whenever there is an indentation on the right side like this, so this is very clear in a penetrated view, but normal X-rays, once you get used to seeing this, you will recognize. So this is the only feature by which on X-ray we say it is a right aortic arch, because there is no other classical feature. And this is again I'll emphasize because I found many students are not very clear about it. This is the shadow of the trachea. I follow it here, and there is the indentation on the right side, and so it's a right aortic arch. Oh, both the students have given the findings, but nobody has committed to the diagnosis. Now, this actually is the patient in which there is a very prominent main pulmonary artery. And the vasculature, I won't say it is decreased, it is normal. And this is very typical of a valvular pulmonic stenosis. But sometimes idiopathic dilatation of pulmonary artery can give such a picture that there is a normal vasculature and the main pulmonary artery segment is prominent. So this is the differential diagnosis. Is actually valvular pulmonic stenosis or idiopathic dilatation of pulmonary artery. This is also a very typical X-ray, and I hope you all can diagnose it. Dr. Pankaj is absolutely correct. This is a very, very typical example. This all is thymus, actually. There is no cardiomegaly. And this patient was referred to as echo for cardiomegaly, class query. But the X-ray gives you the diagnosis. The echo is not even needed. And what is very typical, if you do a lateral in this patient, The thymic shadow will be seen in the most lateral and upper part of the shadow. So this will be thymic shadow and this will be the heart shadow. So you can very well distinguish. But most of the time it is so typical that you don't have to do a lateral X-ray. This is just because this is a teaching session. I am showing that if you do lateral in such a patient, the thymic shadow will appear in the most lateral and uppermost part of the shadow of the heart. Please try to give the finding and diagnosis. The only one person attempting, the two people, one by one they attempt. Okay. Now what I'll like you to see is that this is the first bump in the cardiac shadow. This is the another bump in the cardiac shadow. So what is this first bump? Immediately after the clavicle, if there is a dilatation in the cardiac cylinder, then it is the aorta. And after the aorta, if you see, is the pulmonary artery. So in a child, if you see such an X-ray, that there is a dilated descending aorta on the aortic knuckle, prominent pulmonary artery segment. The vasculature, you may not be able to see maybe the end-on vessels. The multiple end-on vessels also seen. So if you see such an X-ray, then the diagnosis is most likely to be patent ductus arteriosus, in which if you have a good X-ray and the shunt is significant, you can also see a left atrial enlargement. It is not very clear on this X-ray and the configuration. The clue to the diagnosis of the shunt lesion at the aortopulmonary level, ductal level, is that the aorta is dilated, pulmonary artery is dilated, and the configuration will be left ventricular. If the shunt is significant, you will have a left atrial enlargement, of course, in addition to the end-on vessels showing an increased vasculature. So these are the findings which make you diagnose on the X-ray a patent ductus arteriosus left right shunt. This child has clearly cardiac enlargement. It is clearly right ventricular configuration and enlarged right atrium. Pulmonary artery segment is not prominent and there is a decreased pulmonary blood flow. This is classical findings of the Epstein's anomaly. Because I'll show you another X-ray because echo side is a transposition physiology in which you see an increased vasculature. Transpositions, detranspositions who have decreased pulmonary blood flow will not have the end that appearance classical. In them, the heart size is usually not so large. It is not agon size. They mimic the TOF physiology. The agon site is a typical example of the detransposition in which you see the cardiomegaly, increased vasculature, and then the typical shape. And we'll see that X-ray later on. This is very interesting X-ray. See for some time, otherwise I'll give you some hints on this X-ray if nobody picks up. Okay, I'll just ask you to concentrate on these areas which I'm marking 1, 2, and 3. Now I think you can give the diagnosis. If this is a bulge here, then this is a concavity little, and again a bulge. Or somebody is very fond of TFT. Yeah, just see again. I'm giving you a hint. There is a bulge here, then there is a notch here, and then there is a bulge again here. What is this sign? Now you have come up with the right answer. So first you have to describe this, then give the diagnosis. So this is typical X-ray of a coarctation of aorta. This is the site of coarctation. This is the dilated segment of the left subclavian artery, and this is the dilated segment of the descending aorta. So this gives a sign, which is the E sign or 3 sign, whatever way you are seeing it. So you are seeing here is a E sign, and you can see the other way around like this way, and this will be again 3 signs. Now, if you do a varium swallow, then you will see wherever there was a dilatation, you will see a negative shadow, and where there was a constriction, you will see a bulge. So this is the area bulge, and this is the two dilatations. So this is the E sign, and this is, as I told you, 3 sign. I hope you got it. This X-ray is given to you, then you can diagnose typical coarctation. Also, you can say that it is a discrete coarctation. If the coarctation is associated with arch hypoplasia, you will never get a typical 3 or a E sign. Now, what else you look in such X-rays? I'll show you. You look for the rib notching, which is very clearly seen in this X-ray. Not in that X-ray, but the other X-ray which is this is the rib notching. The lower margin of the rib has wavy shadows, and this rib shows it very clearly. So it is seen after the age of 3 years and mostly between the 3rd and the 8th year. Again, this X-ray is interesting. I'll give you a hint to concentrate on 2 areas, and then you might get the diagnosis. Concentrate on this area and concentrate on this area. And if you concentrate and see, probably you'll get the correct diagnosis. You're not giving the full diagnosis. You're right. But there's something with the arrows show. You're partly correct, but what I wanted from you is grossly enlarged cardiac fluid. You describe smooth cardiac borders, and these 2 areas there is air in the pericardium. This is air, and above that is a very thin pericardium. That's why I wanted this reason. This is air in the pericardium, which gives you the idea that it was depth, and once the air is there, then it is delineating the pericardium. So the pericardium is not ragged, not very thick, so that it gives a impression that it is a thin pericardium. So it has to be non-infective and not containing blood. So it is a thin pericardium and it has been tapped. And so you should say there is a pericardial incision, post-step, thin pericardium that is a non-infective. Pyogenic infection causes a very much thickening. Tubercular also causes a thickening. So it is not the infective effusion. I will again request you to please give the findings and then commit to the diagnosis. No volunteers. There is not an interactive session. Okay. Nobody describing the, I have to describe the X-ray and give you the diagnosis. ET. In the configuration of the heart, it's the lifted apex, not down. So this is more like the right ventricle. There is an increased vasculature very clearly. Both the hilar are prominent and there are a lot of unknown vessels. So clearly it is an increased vasculature. Excuse me. And there is a no left atrial arm, this is the left bronchus, and clearly right ventricular configuration. So the shunt lesion is there, and in this you will commit that it is a atrial level shunt. This I have given the findings. This is a 4-year child with a murmur of the VSD. If you see such an X-ray, you can give the total diagnosis in this patient. I find only 2 students who are trying to attempt Dr. Pankaj and Srila. But there must be many more, I think so. This is a cyanotic patient. You can revise the diagnosis. A cyanotic patient with a murmur of a VSD, no MDR. Give another chance to both the people who tried to attempt. Murmur clearly of VSD, second sound normal, no MDR. The patient is blue, not glisten. Patient is not blue. Try to look at the configuration more carefully of the heart. I am giving you a patient is acyanotic, so it's unlikely to be decreased flow. Okay, I'll give you the Yeah, very good, very good. The person now has written the correct answer. This is a classical X-ray of a garbode with those findings. That if you have a patient who is cyanotic, isolated VSD murmur, no significant shunt, but RA is not. So it is an LV shunt, the so-called garbode defect. Very good, doctor, I think. Sheena. Okay, next. This is a acyanotic child, 4 years old, normal cardiac auscultation. It's a very unusual X-ray and a very rare condition. So you may attempt to describe, uh, you may not have seen such a patient. But because it's very interesting and very classical, that if you see it again, you will recognize, I put it up. So I'm saying it's a very rare condition. So cardiomyopathy is not a rare condition. So I think if you are given a hint, you should catch it. What is the other person? I didn't get the answer of the other person. Absent pericardium. The absent pericardium, the bulge is on the left side mostly, not on the right side. So I tried to explain. This is a typical shadow of the right atrium. Bulge on the right side of the cardiac. So it's a markedly enlarged right atrium. But the left heart border doesn't show any humps and anything specific. The vasculature is not increased. So this was a case of idiopathic dilatation of right atrium. And that is why I gave the hint that there is normal cardiac auscultation to distinguish it from the abstinence anomaly, because abstinence you can get huge right atrial enlargement. But if cyanotic normal cardiac auscultation, then very unlikely to be abstinence. We have seen a couple of cases like this, hugely enlarged right atrium, and there is no cause could be found. It is a described entity, but a very rare entity. This is a very typical X-ray. You can give almost a correct diagnosis on just the X-ray. What did it show? Show it again. The answer. The answers are disappearing very fast before I can read. Let them remain for some time so that I can know what they're saying. This is the answers now. Absent pericardium in this one. Actually, the two of you have said one thing correctly, but I have to move this to bring the okay, further slides. So I have to move this. I cannot keep it here. Poonam, if I keep it there. Slow, okay for tricuspid atresia. The configuration is also very typical of tricuspid atresia. Broad apex. The left ventricle without the RV looks like this with a broad apex. But the very important thing you have not pointed out that in patients of tricuspid atresia, usually right atrial border is prominent and merges into the SVC border. And here you see absent right atrial border, hardly any right atrial border. And this is very, very typical of juxtaposition of right atrial appendage, because then the right atrium is not here, it is shifted. So this area is full because of the juxtaposed right atrial appendage. So this becomes LP configuration, right atrial border not seen, decreased pulmonary blood flow, which is classical for tricuspid atresia with juxtaposed right atrial appendage. Such unusual configuration you can also get in univentricular heart. In them also you can have a juxtaposed right atrial appendage. The, but the first diagnosis should be with this configuration, tricuspid atresia, and with this absent right heart border, juxtaposed right atrial appendage, and of course decreased pulmonary blood flow. And juxtaposed atrial appendage can occur with tricuspid atresia. So this is a very classical X-ray for that. So this is a very typical X-ray of what condition, as is the detached position within tip septum. And this is the classical markedly enlarged heart and echo-site appearance and narrow pedicle. So with that, it is very important to have a narrow pedicle, no pulmonary artery segment, no main pulmonary artery segment, because if pulmonary artery is posterior, so you have an increased vasculature, but no pulmonary artery segment. And typically there is a much increased flow in the right upper lobe. This all features fit into the classical detached position, and most likely with so much of cardiomegaly and not so much of flow, so intact septum causes that. Agon size, cardiomegaly, narrow pedicle, increased vasculature, flow more on the right upper lobe, and this all fits very well into detached position. Nobody is attempting this X-ray. Now, I'll give a hint to you. The same patient's barium swallow is there. Now try to attempt. Fit in the barium swallow with the PHS and try to make a diagnosis. Yeah, two people are correct. But again, you are not giving the description. Why you are saying it is MS? You have to describe the X-ray, give the findings, then put the diagnosis. Otherwise, you get 50% marks only. You should say no cardiomegaly, prominent main pulmonary artery, left atrial appendage prominent. This is appendage area because it's much below the left main pulmonary artery. So this come below the main pulmonary artery is the left atrial appendage and left atrial enlargement with some prominence of the upper lobe vein, and barium swallow shows a acute curve. This is to distinguish in patients in which there is a significant mitral regurgitation. Then the curve is very broad like this. This is an acute curve typical of mitral stenosis. So with putting these two axes together, it is a mitral stenosis with prominent left atrial appendage. And if you see a good atrial appendage, that is okay for mitral stenosis. But if you have a mitral stenosis patient and you don't see a left atrial appendage, then you must think that either there is a clot sitting there or the patient had undergone a previous surgery, so LA appendage is not there. Otherwise, in rheumatic mitral valve disease, LA appendage is always enlarged. If it is a pure MR, you don't see a left atrial appendage. Think of non-rheumatic mitral regurgitation. So recognition of LA appendage is very important. So this is a classical X-ray and the barium swallow of mitral stenosis with moderate pulmonary venous hypertension. I know in the projected X-rays, the venous hypertension we may not be able to grade very clearly. The same answers are there. Okay. Thanks. Okay. So I'll go ahead with my description. Now this patient has a typical LV configuration. This is a classical LV configuration. Now this is not the main pulmonary artery. You see a bulge in the main pulmonary artery. So main pulmonary artery not seen. This is the aortic shadow is prominent. There's a very prominent pulmonary vasculature. This is of course the left atrial. So there's a large left to right shunt. But you are not seeing main pulmonary artery, but you are seeing a dilated aorta. So what should you think? And this patient, if it is he is dusky also, then clearly it is a persistent truncus arteriosus. So this was a patient of persistent truncus arteriosus. In many of them, you see a right aortic arch, which we are not seeing here, but the classical features of this X-ray are LV type of enlargement, left atrial enlargement, increased vasculature, prominence of aorta, and no prominence of main pulmonary artery. That will make all the features consistent with the diagnosis of persistent truncus arteriosus. Try to be quick in answer so that we can finish the exercise with that. One of the doctors, like Dr. Pankaj, is a little near to the diagnosis. Number two, but he is got some findings, but not still total diagnosis. Very good, these last two, Pankaj and Srinath. But the total diagnosis should be that there is a RV configuration of the heart. See, this apex is lifted up, it is not coming down. So this is the RV configuration. And interestingly, it is only prominence of the right SVC. It is typical supracardiac PVC. You have the prominence of the left vertical vein also, or whatever you want to call it. So this is a prominence here, then innominate, and then SVC to the upper part of figure of 8. But here, this is absent. This is absent. The only prominence is the right SVC, which is markedly prominent. Of course, there is increased vasculature. So it is a type of a supracardiac PVC in which the drainage is directly into the SVC, not through the vertical vein. So this is a very interesting X-ray, and by the X-ray you can make the diagnosis. You have seen the patient. Patient is blue. Patient is finding of an ASD left to right shunt with the blue patient, but you see the X-ray. There is no prominence of the vertical vein, but only right-sided SVC. So this is a TAPVC direct to the right superior vena cava. try to be quick so that we can see all the X-rays which are not. See, first I will tell the people who are given the X-rays, it can never be a Eisenmenger, somebody written Eisenmenger, because this patient has a decreased pulmonary blood flow. So, and the main permeability prominent, but there are no hilar vessels. So it can never be an Eisenmenger. It's a very big, enlarged right ventricle, right atrium. This is a typical RV configuration of the heart. The right atrium is markedly enlarged, but the main pulmonary segment is very prominent, and there is a decreased pulmonary blood flow. Putting all this together, it is a typical X-ray of a very critical PS with right to left atrial shunt, and it has to be with tricuspid regurgitation because there's so much of RA enlargement and so much of enlargement of the heart, of congestive heart failure. So this is a very, very typical X-ray of the critical PS showing cardiomegaly, RV configuration of the heart, and enlarged main pulmonary artery with marked decreased pulmonary blood flow. And the patient is low because there is decreased pulmonary blood flow. The shunting mostly at the right side, at the atrial level. Nobody has paid attention to this shadow. It's coming from ear to ear. This X-ray does not show any cardiac enlargement, and very clearly it shows the L Malfos aorta. This is the shadow typical of L Malfos aorta. See, there are no bumps or humps here, no notch for aorta, no notch for pulmonary artery. A smooth shadow of the left heart border with the decreased pulmonary blood flow, no cardiomegaly, is the classical for L transposition with VSCPS. This, I think, everybody should say. A very typical X-ray, and we must have all seen this X-ray. Only one person seems to have seen this X-ray. So typical. Severe pulmonary venous hypertension, this is the ground class. And we must remember that this is most typical for obstructive TPVC, and try all your means to diagnose it. Another very typical X-ray. Kids, I have got a couple of very good X-rays. Give some answers. One person has reached to near diagnosis. This is a normal heart size, dilated, markedly dilated hilar vessel, RPA and LPA, a decreased pulmonary blood flow. This is TOF with absent pulmonary syndrome. The two people are good. Good. I try to read this X-ray. Quick, 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 quick. There's a lot of things in this X-ray. There's no cardiac enlargement. You can clearly see there's a decreased pulmonary blood flow. Absent right heart border is there. But there's a prominence in the hilar area of the left pulmonary artery, but not in the main pulmonary artery. Aorta is prominent. So there is a PSGPS physiology clearly, but with the absent right heart border. So you are right in saying juxtapositional appendage, and there's no main prominence of the main pulmonary artery, so it is a decreased pulmonary blood flow causing that. But there's a prominent LPA. This is the LPA shadow, and then if such a shadow there, then you have to say that this is a toss physiology. That suppose right atrial appendage, then this bunch could be either due to the peripheral pulmonary artery stenosis on the left pulmonary artery, or sometimes it could be that there is a extra flow coming to the left pulmonary artery in the form of either a collateral or a shunt, but we don't see any shadow of the collateral.